Well, thanks for joining us, Dr. Rains. Maybe you could tell us just a little bit about what you do.
Yeah, absolutely. And thanks for having me on. So I am a nephrologist at Beth Israel Deaconess. Have been up here ever since I graduated from med school at Sinai back in 2015, did my residency, did my fellowship up here. I do clinical nephrology up here, and then do a decent amount of research related to this disease called Mesoamerican nephropathy. So folks who are ever interested in learning more about that, I write the Wikipedia and I highly recommend it.
Okay, wow. All right, I'll have to check out that Wikipedia. Amazing. I'm meeting an actual Wikipedia author right here. Love that.
Let me tell you, the selection process is not rigorous.
Right. Cool. Well, today you're going to teach us about hyponatremia in the ED, how to think through some of these issues when we see them. So yeah, let's go. Teach me.
Awesome. And I have some slides prepared that'll just be kind of a general outline, but we'll sort of chat about these different things. So I have this sort of approach to hyponatremia structured really around two core questions. The first question is, do you need to do something about hyponatremia right away? And I guess as we're jumping into hyponatremia, we should sort of clarify what we're talking about when we talk about hyponatremia. This is really a condition where you're going to see serum sodiums less than 130, but really when we talk about hyponatremia, that is sort of more complicated to manage. It's less than 125, less than 120, and even lower than that, that we really start to sort of think hard about some of these questions. Question one here, do you need to do something right away, is really about that sort of second part. Is the hyponatremia itself going to cause a problem? So there are a couple of situations where you do need to act now because the hyponatremia itself will cause a problem. There's a lot of situations where you probably don't need to act right away. You can sort of take a breath, figure out how to make sure you have a stable plan to sort of gradually and in a controlled fashion correct the hyponatremia. And in general, you'll see better outcomes in that context. So the times when you need to act now, I think most commonly is going to be based on symptoms. So if you see severe symptoms, those are things like seizure, coma, unresponsive patients, respiratory arrest. This is a clear indication you need to do something right away for this hyponatremia. Oftentimes, we'll also do something right away or relatively right away when folks have moderate symptoms. Now, the moderate symptoms are a little bit less sort of specific when it comes to hyponatremia, things like fatigue, confusion, lethargy, nausea, which is why, again, it's a little bit more hand wavy. But if you are pretty convinced that those symptoms are driven by the hyponatremia itself, it's typically a good idea to do an acute treatment. And I'll talk a little bit later about kind of what the acute treatment is. But the typical concept for acting now is you want to bring that sodium up 5 milliequivalents per deciliter as quickly as possible.
Just 5.
Yeah, so 5, 5 kind of spot on, and then you don't really want to push it up too much more than that. Most of the time, you will see improvement or resolution of these symptoms if you do that kind of quick improvement by 5. Again, if you're not seeing improvement to the extent that you want, you should push it up higher than that. But, with any sort of action that you're taking to push your sodium up, you are increasing the risk for complications arising in the context of sort of over rapid correction of sodium.
Right.
So that's kind of the balance you're striking. And 5 tends to be a pretty sweet point where you're not going to run into complications of treatment, but you address a lot of the acute issue.
Okay, cool.
Yeah. The causes, and sort of we touched on this a little bit earlier, some of these acute hyponatremias due to sort of massive water ingestion are times where you can increase the risk for, I think the most dreaded complication of hyponatremia or acute hyponatremia, which is sort of brain herniation. And so those are also times when, someone's coming in acute, typically they are going to be symptomatic in this context as well. But they may not have these super low sodiums in like the hundreds, low 100 teens, but still merit pretty rapid correction. So if you sort of have these clinical scenarios, it should just kind of raise the index of suspicion that this might be hyponatremia causing a problem itself and something you need to treat right away.
Okay.
Likewise, post-procedural iatrogenic hyponatremias and hyponatremia in the context of intracranial pathology are other sort of situations that you think about in this context where even with, not super low numbers, you can still have an increased risk for complications from hyponatremia.
And is that due to an SIADH type of picture when it's post-procedural or intracranial pathology?
So this is typically no. And again, you can certainly see an SIADH type picture with these sort of pathologies, but this is more, an acute hyponatremia being driven by one of these, or the intracranial pathology is there something that is going to increase your risk of a brain herniation?
Oh, so they're having hyponatremia for another reason, but they also have this. So now you have to be more worried.
Exactly.
Gotcha.
It's just sort of a situation where you might be a little bit more worried.
Okay. All right.
And then likewise, sort of the acuity matters. It's something that's often really difficult to tell, particularly for folks in the ED with hyponatremia, because it's very rare that we have a sodium level within the past 48 hours for anybody who's coming in through the ED. So this question of acuity is always a really kind of tricky one to figure out. So the general concept is acting now in the context of acute hyponatremia tends to be good because, one, if it's acute, there's often, risk for the hyponatremia continuing to change, continuing to worsen. There's also sort of increased risk in the setting of acute hyponatremia for developing complications of hyponatremia. When you have sort of a more chronic hyponatremia, one, it's probably less likely to change rapidly off the bat if you're not doing anything. And two, it's less likely to develop complications. So you can sort of take a breath and figure things out for a little bit more.
Okay. Question on this slide. So if you see someone, because on the okay to take your time, it's like greater than 120. But if you see someone, which I've seen before, someone in the 110s or even like 111 or something, but they don't have any of these symptoms, are you going to act fast, or is it okay to take your time?
Yeah, great. And I didn't spend enough time on that cell, so thank you for bringing this up. So if someone's asymptomatic with the sodium less than 120, and you don't think that this is something acute that's likely to change rapidly, that their clinical situation is likely to develop, I would still say it's generally best practice to not do this rapid correction right off the bat. It is fine to take your time in this context. So the cell may not actually be written the most clearly, but so anyone who's asymptomatic or with mild symptoms with the sodium greater than 120, pretty much always okay to take your time. Anyone who's asymptomatic at virtually any level of sodium, as long as you don't think they're likely to change quickly, is probably also okay to take your time. That's sort of a better clarification.
Yeah, great.
Awesome. So we can move on to sort of the second key question then, which is how much risk of injury due to overcorrection is there for your patient? We think a lot about sort of the problems that are caused by hyponatremia, but we think almost as much about how much risk there is for actually causing problems as we're trying to treat this.
Right.
Much of the time, we are okay to leave a patient and kind of take our breath, and they're not going to develop those complications of of the hyponatremia itself. And it gives us a chance to really think about a slow, easy, steady correction of their sodium. The reason we think about this injury, and the sort of classic one that we worry about, is this osmotic demyelination syndrome. Really very sort of nasty. It doesn't happen that often, but when it does, it can be a really devastating complication. That's what we worry about. So I sort of here have this divided into kind of the high risk situations and the low risk situations. High risk situations, so one, the lower the sodium it is, the greater the risk there is of sodium sort of correcting really dramatically. So, I have sort of in here, it's low risk if the sodium is greater than 130 because your body isn't really going to try to correct any more than, to 140 milliequivalents per liter. So, going from 130 to 140 as opposed to 105 to 140 is a much less dramatic change and a much lower sort of risk scenario. So that's really why we worry about people with very low sodiums, because if they do overcorrect and try to get themselves back to 140, it's just a lot more of a change to get to 140. Second, chronicity really matters in this context. Folks with an acute hyponatremia have pretty low risk of injury from overcorrection. And that's just because there hasn't really been as much equilibration to the hyponatremic state. And so some of the concerns that we worry about really with water shifts aren't as pressing in that context. Whereas if someone has been living at 105 for weeks and then suddenly jumps back up to 140 milliequivalents per liter, it can be a big issue.
Yeah, I was going to say, because I've had a patient, a few times patients sort of drink themselves into hyponatremia, whether it be ecstasy, just drinking water, or psych issues. And if they're just sitting in the ER, they're going to bring their sodium back up just by urination, whether we do anything or not. And I've noticed that they can make huge corrections in the ED, but I haven't seen complications from that.
Yeah, and it's just because, that acuity has been, again, so fast that, their sodium dropped down, it came right back up. Their cells didn't really have a chance to get, used to kind of the new fluid salt balance. And, it doesn't lead to those sort of shifts that actually cause the cellular injury that lead to the complications of sort of hyponatremia overcorrection. There are a couple comorbidities we think about as well in this context that we worry about risk for: hypokalemia, alcoholism, malnutrition, liver disease. These have been showed in a number of epidemiologic studies that just folks who are coming in with hyponatremia with these sort of features tend to have increased risk for the complications of overcorrection.
Okay.
Yeah, and then the cause actually does matter as well, and I'll talk about that a little bit more. But the cause is really, when you sort of think about what's causing it, it's all about thinking, can the body actually mount a sort of normal response, which is pee out all this extra water, get myself back up to 140 or not?
Maybe we could just spell out specifically what bad things happen when you do correct too quickly.
Yeah, so the bad thing that happens, and really the key thing we think about, is osmotic demyelination syndrome. So this is basically, the historic term that was used was central pontine myelinolysis. We've moved to sort of osmotic demyelination syndrome because it's not limited to the pons in terms of where that central neurologic injury can happen. But functionally, it leads to pretty significant motor deficits. The most severe cases are even like locked-in syndrome. It is something that is partially reversible potentially, but can lead to permanent irreversible neurologic injury.
And this is, I've not seen this complication. Is this something that happens right away, or is this something that develops much later in the patient's course?
Yeah, and fortunately, I have never seen this complication in person either. I have seen cases on it, including consulting, doing telehealth on cases where this has arisen. In my experience, it happens within days to a couple weeks of the overcorrection, where symptoms don't necessarily develop instantaneously. They can really arise, even after you think that the patient has sort of done okay, you discharge them home, and then a few days later, they start to develop sort of weakness and end up coming in. And osmotic demyelination syndrome is typically diagnosed by neuroimaging. And they come in with weakness, they get neuroimaging, and you see this sort of characteristic changes.
Okay.
So this is sort of the chart that I kind of think about as my general gestalt for approaching hyponatremia. It's sort of a 3 rows by 3 columns approach, where you have along your rows, first looking at someone's serum osms, second looking at someone's volume status, and third looking at someone's urine osms. So there's a little bit of a breakdown within the volume status, looking at urine sodium as well, that I'll talk about.
Okay.
And for those, you're looking at whether they're low, normal, or high. So the first question with the serum osms is this true hypoosmotic hyponatremia? Which, when we talk about hyponatremia, is what we're talking about. You should have a serum osms less than 280.
Because there's, the whole problem is that they're dilute overall.
Exactly. The assay for hyponatremia, really, the reason we care about it, and this is something that folks are lectured on from sort of med school onward, is we care about, hyponatremia is a problem of water, not sodium. So these other situations where the sodium level is low, but there's not actually a issue with low osms, are really situations where there's some other, osmotically active factor present in the blood that is going to sort of take up some of that role that typically is filled by hyponatremia. These are sort of our pseudo hyponatremias, and the most common one that people run into all the time is from hyperglycemia. So again, there's a corrections that you can do for hyperglycemia to determine what your actual sodium is and help determine whether that is, really a hyponatremia or not. I think the serum osms, though, are also often useful. I, for a long time, was sort of agnostic about getting serum osms. I sort of come around to it because there's really only one opportunity to get a sense of what your serum osms are, and that's when you first see that patient. And if you're chasing something that isn't real, it can, it can lead to a lot of unnecessary therapy, admissions, et cetera. So start out with the serum osms, confirm that this is a true hypoosmotic hyponatremia.
And so if they're hyponatremic, but their osms are normal or high, then that it's either because they've got a lot of glucose in there, is it albumin? Is it, when you say protein there?
Yeah, so this is often really more than protein, it's like paraproteins. So like a paraprotein disease, significant like hyperlipidemias and that sort of thing can cause issues. You can see it iatrogenically when folks are getting mannitol is sort of like the classic situation.
It sounds like these are basically not these things, whether it's the glucose, the lipids, the proteins, are providing an osmol or gradient, are providing an osmolality such that the person isn't going to develop symptoms from that type of a hyponatremia?
Exactly. It's the osmotic balance still isn't thrown off. There's just other sort of osmotically active substances in the bloodstream that are sort of playing the role of sodium in that context.
Okay.
And so you don't worry about sort of the complications of hyponatremia in this context, because it's unlikely that they would, the osmotic issues aren't present if there isn't sort of a hypoosmolarity.
Yeah, okay.
So moving on, once you've sort of confirmed that you have a true hypoosmotic hyponatremia, the next thing you look at is volume status for a patient. Basically, what you're trying to determine here is there a appropriate reason for ADH to be turned on in these patients? So the kind of one that we see pretty commonly is this sort of hypovolemic hyponatremia. And the even more classic one is sort of volume depletion in the context of thiazide diuretics. With this, your body is sensing that you don't have enough volume. It's sort of appropriately responding by holding on to water through increased ADH release. And so it's not, it is a situation where ADH, yes, is causing a potential issue, but is trying to sort of address another issue, which is the hypovolemia. Urine studies in this context can be useful to sort of separate these out. In particular, sort of the diuretics. If they've taken the diuretic recently, sodium should be elevated. If they're volume depleted from another cause, or if they haven't taken the thiazide diuretic in the past day or so, you can still see low urine sodium. And that's, again, just showing the kind of normal adaptive response. Someone's hypovolemic, they're trying to hold on to water, they're trying to hold on to salt, they're trying to keep as much, in their bloodstream as possible to, address that volume issue.
Unless they're being overruled by these diuretics that are forcing them to pee out sodium and electrolytes.
Yeah, exactly. So the thiazide diuretic, the reason you'll see the elevated sodium is just because we're basically blocking one of the kidney's adaptive responses to try to hold on to sodium as much as possible.
Okay.
The other situation is the hypervolemic situation. And again, this is situations where your kidneys are also being they're being stimulated to, or your body's being stimulated to hold on to fluid, although these are often maladaptive situations. So things like cirrhosis and congestive heart failure, you are having, often inadequate kidney perfusion. And so you're getting the stimulus. Again, it's just a maladaptive stimulus in this case for ADH release to hold on.
The kidney, it's like the kidneys don't think there's enough fluid, even though there is. So they start retaining sodium and fluid.
Exactly. And so, cirrhosis, CHF are the classic volume overloaded with low urine sodium situations because you're getting inadequate kidney perfusion. Chronic kidney disease, you often will get a more elevated urine sodium, and that's just because your kidneys are already diseased and they're not, holding on to sodium optimally because.
And so the CKD is making them hyponatremic, or are you saying that they're hyponatremic and the CKD is making their urine sodium go up?
The CKD is making them hyponatremic, and the reason that their urine sodium is sort of more elevated in the context of CKD is because they also don't hold on to sodium as well either. So, a normal healthy kidney can really reclaim like 99+% of the sodium that's filtered. As you develop chronic kidney disease, you run into issues with not only the filtration, but also the subsequent sort of processing of sodium in your kidneys.
Okay.
So that's, again, our sort of low, high situations. These are real hyponatremias. These are things you need to treat. Most of the time, the treatment is going to be addressing those underlying causes that you're talking about. When you have someone who has sort of normal volume status, you then move on to look really at urine osms, and that helps you determine kind of the different causes of hyponatremia from there. So starting again with sort of low urine osms, again, less than 100 is typically what I think of in the low urine osms. What we're mostly talking about is a solute-solvent imbalance. So it basically comes down to the fact that your kidneys can't pee out pure water. They have to have some solute in the water that they're peeing out. And so if you have just so much more water or fluid coming in than solute coming in, at a certain point, you're overwhelming your kidney's ability to sort of compensate. So again, you'll see these very dilute urines because your kidneys working to dilute your urine as much as possible. It's just you're not giving it enough solute to work with to actually correct the hyponatremia.
So you're still losing solute because you're forcing the kidney to pee so much, but it's still going to be as dilute as it can possibly be.
Yeah, your kidneys just can't dilute any further, and so they can't correct the hyponatremia the way they're trying to.
Yeah, that makes sense.
The next group is sort of the normal urine osms. These urine osms sort of around 300. These are super rare. I've never seen either one of these, but it's sort of, the classic ones you think of are thyroid and adrenal disease. And it's basically the thyroid disease, you really probably only see this with something super severe like myxedema coma. And with sort of adrenal disease, it's really like adrenal failure that'll produce that. And that's just due to sort of systemic effects throughout the body that seems to drive that.
Okay, so would that be sort of like trying to understand? So this is a person with the normal volume, low sodium, and is the urine, I'm just trying to understand those hours, the urine sodium is above 20, is it saying it's from above 20, or is that?
Yeah, and so basically, returning kind of the low one, your urine sodium is going to be low because you're just holding on to as much solute as possible. With this, your urine sodium is typically, not low because the issue isn't, it isn't sort of your kidneys are holding on to as much as possible and they're just, unable to compensate because they're not getting enough solute. Rather, the issue is there's something wrong or maladaptive with the kidneys. Again, with this sort of middle group, the myxedema coma, the adrenal failure, this is such an unusual situation to run into that I usually tell people to not worry about it, because typically if this is going on, you're going to have a lot of other clues
Sure.
as to what the issue is, and probably a lot of other things that you have on your plate beyond the hyponatremia.
Yeah, sure.
But the SIDH, and I think this is one where it really does come down to this kind of discussion of the elevated osms and the elevated urine sodium. This is truly sort of a maladaptive situation where the body is releasing ADH inappropriately to concentrate the urine. Typically, you don't have a low urine sodium because you don't have a trigger for low urine sodium. These are euvolemic patients who don't have volume issues. So your sodium is kind of typically somewhere around 40 or so in the urine. And with SIDH, again, you'll sort of classically see kind of a much more elevated range, the 300 to 600 or even more for your urine osms.
Got it.
And I think, a lot of this will ultimately become relevant when you think about how you're going to treat the patient long run. But in the ED, I think this is also relevant because thinking about what might be causing it also helps you think about your risk in particular for overcorrection. And so sort of these situations in particular, the low volume or the low urine osm situations are ones where it's pretty easy to correct what is causing hyponatremia. And once you've corrected sort of what the trigger is for hyponatremia, the body is going to try to bring itself back to its homeostatic state. It's going to try to go back up to 140. And so you're at risk. These other situations, these are just things that we don't correct as quickly. We're not going to correct cirrhosis CHF or CKD quickly and lead to a rapid, recovery of kidney function, at least when you're talking about a volume overloaded cirrhotic. And with SIDH, we're not typically going to stop the trigger for SIDH quickly. And so these groups tend to be a little bit less likely to overcorrect than these groups.
Okay. Let's go through causes of SIADH.
Yeah. So there are a wide variety of different causes that we think about here. I would say the big categories that I always think about when you're talking SIDH are medications and intracranial pathologies. So you see SIDH like with classically with the subarachnoid hemorrhage. But, in the context of a lot of different intracranial pathologies, you can think of sort of an inappropriate ADH release. And then there's a huge variety of medications. I won't run through all of them here that can also lead to SIDH. I'd say just a couple big categories to think of. So opiate pain medications are one that I always think about when in the context of SIDH. And this is challenging because pain itself can also result in SIDH. So again, a review of the patient's medication list is typically the first thing that I do when I'm evaluating someone who has hyponatremia and it looks like SADH, because oftentimes it'll be there in the medication list. So the last part I have is just sort of this question of what do you do when you're trying to manage hyponatremia in the ED. So typically, this is a workup I recommend for everybody. They should all get a serum osmomes, a urine osmomes, and then a urine sodium and a urine potassium. The urine sodium and urine potassium help us calculate something called electrolyte-free water clearance, which is basically a way to actually figure out what your correction rate is likely to do. I'm happy to talk about electrolyte-free water clearance. It's a pretty niche topic though. And so
well, I'm understanding the urine sodium because we talked about that on the prior slide, but the urine potassium is, yeah, what is that about?
So it's actually the urine sodium and urine potassium go into the calculation of something called electrolyte-free water clearance. So basically, if you look at your serum sodium and you look at the sum of your urine sodium and your urine potassium, you can tell what your kidneys are doing naturally as they pee. So if your urine sodium and potassium sum is less than your serum sodium, that means that when you're peeing, you're actually getting rid of water in this context, because there is more solute than more solvent than solute when you're peeing out sort of this fluid that has low levels of sodium and potassium.
Okay.
If the sodium and potassium is elevated in the urine, then you know that in your peeing, you're actually retaining free water because the urine is functionally more concentrated than the blood at that point.
Okay, yeah, I never heard of that. Okay. How come when you're adding up, you're not adding up the sodium and potassium in the serum and the sodium and potassium in the urine? Like, shouldn't you be comparing apples to apples?
Yeah, you could, it's just, the serum potassium is, what,
Like
it's 5.
Okay, all
yeah,
right.
It's negligibly small, whereas that's not the case in the urine. It's a, important osmolyte in the urine because it can reach higher levels.
Okay, all right, that makes sense. Okay.
So anyway, the workup for everybody includes the serum osmomes, the urine potassium, the urine sodium. We then sort of jump into the different scenarios that I laid out. So the hyponatremia itself is acutely dangerous. You need to do something now. The recommendation that I have, give 100 cc's of 3% hypertonic saline, and you can repeat that as needed. With, again, the goal is to increase the sodium by about 5, I don't know why I said cc's, but 5 milliequivalents per liter as soon as possible. You want to then make sure you just have close urine output and serum sodium monitoring every 1 to 2 hours. And the urine output, again, the reason you're keeping an eye on this is because most of these hyponatremic states are going to be high ADH states, the exception being sort of the low urine osmomes situation where you have that solute-solvent imbalance. But most of these are going to be high ADH states. You shouldn't make a lot of urine in that context. If suddenly you're opening up, that suggests that this high ADH state may be changing. ADH may be turning down. And in that situation, you're at risk for overcorrection. So with all these situations, close urine output monitoring is important, but particularly if you're doing sort of an acute treatment of rapidly increasing the sodium, just keep an eye out to see whether that appropriate rapid increase is going to turn into then an inappropriate ongoing overcorrection.
Mm-hmm. And what do you do if you get yourself into that situation where it is overcorrecting?
Yep. So, the water is your friend in this context. So D5 water is great. The other thing that you can do, and I recommend this, and I talk about this a little bit in sort of the next row here, use of desmopressin or DDAVP. This is basically the desmopressin break. And what it's doing is, so I talked about the risk for overcorrection arising typically when, the situation where ADH was sort of elevated is now turning around and ADH levels are starting to drop and urine output's starting to pick up, what you're giving is just basically producing a high DH state again by giving ADH, in this case, desmopressin. And so you're preventing that, you're preventing that overcorrection by just basically maintaining a high ADH state.
This is putting the brakes on fixing your hyponatremia. DDAVP is putting the brakes on that process.
Exactly. Yep. So,
and this is for cases where hyponatremia isn't so bad, but they may be overcorrecting too quick on their own.
So there's a couple different scenarios for this. And, again, if someone is overcorrecting, I think that putting the brakes on with DDAVP is always useful. I also think that if you know that there's a high risk for overcorrection, I often just, without them even starting to overcorrect, start the DDAVP off the bat. So that way, we can just in a very slow, controlled fashion, bring their sodium up at a, safe rate.
But I imagine, if I was doing that, I'd be worried I'd be making the hyponatremia worse.
And, with the DDAVP, so DDAVP always goes hand in hand with hypertonic saline. So you're putting on the DDAVP to control for overcorrection, and then you're giving hypertonic saline to sort of begin the process of correcting. With it, as you said, that's exactly right. If you just did the DDAVP, there's nothing that's going to help this patient correct their hyponatremia. And ultimately, that's the goal, is we want to correct the hyponatremia. So the DDAVP just stops the overcorrection. The hypertonic saline drip then helps with the actual correction process.
Okay, so you're always going to do them hand in hand together.
Exactly. Again, you have that overcorrection scenario that you had talked about. Sometimes you'll just give DDAVP and, not hypertonic, because again, they've overcorrected. You want them to sort of creep back down to a safe range again. But then you'll typically keep the DDAVP on and, start the hypertonic up again and bring them up at a nice slow state.
Okay.
Nice slow.
Yeah. Okay.
And then finally, the last situation, sort of the hyponatremia isn't acutely dangerous. There's low risk of overcorrection. There, I usually don't do DDAVP off the bat. I'll just, try to correct the underlying issue. So again, if we're talking about like a solute-solvent imbalance, you'll try to do increased, solute intake, get them to eat, get them to, do salt tabs if you want to. I favor eating, and particularly protein over salt always in this situation. If it's SIDH, put them on a fluid restriction, allow things to sort of gradually correct. So most of the time you're going to be in this kind of third row where the hyponatremia isn't acutely dangerous. You have a relatively low risk of overcorrection. And there you just have relatively close monitoring and doing sort of the fluid management, whether that's a fluid restriction or whatnot, to sort of help kind of gradually bring up the sodium levels.
So a couple questions I'm thinking of. One, going back to the second one, when you said, in certain cases, you're going to start at 3% saline, the hypertonic, to bring the sodium up, but to keep it going slowly, you put the DDAVP on. Is there a certain rate you would just automatically put that drip at, or do you do it on case-by-case basis?
Yeah, so, it's a little bit case-by-case basis, and there's some weight calculations that you can look up for the precise things, but it typically ends up being about 30 cc's an hour of 30% hypertonic saline. And so that's a pretty good rule of thumb for, how to start folks off.
Okay. All right. Yeah. Just to know that balance point between the saline and the DDAVP, around 30 cc's sounds about right. Okay. And then if we could go back to the slide before and talk about, how you would manage each of these situations where we're not talking about an acute situation. So like just running through all of these, I guess we could start with volume, someone who's volume down and hyponatremic.
Yeah, for sure. So, this kind of talking about the treatment for each of these, with these sort of volume depleted folks. Again, the management for both the thiazide diuretic and just general volume depleted is going to be relatively similar. You want to you want to give them volume. With the thiazide diuretic person, you obviously also stop the thiazide diuretic. And you want to give them volume in a way that you are also sort of thinking about overcorrection. So again, we talk a little bit later about use of DDAVP to stop overcorrection rapidly, because these folks are at high risk for overcorrection. But typically you'll give them, if they're at risk for overcorrection, DDAVP, and then hypertonic saline. And hypertonic saline is actually pretty decent volume as well. You can do other sources of volume too, but typically with this, I'll put on DDAVP, give them hypertonic saline, and oftentimes
typically with these patients, I know in the ER, we're going to be giving, like if we're trying to bring someone's volume up, we'll be giving LR or NS.
Yeah, and those are situations where you can definitely have overcorrection. It's not necessarily the wrong thing. I mean, obviously, if someone is hemodynamically unstable, they need volume acutely, you've got to take care of that first. And oftentimes it can be useful to sort of give them that volume while you're getting DDAVP, and then put the DDAVP brake on to stop overcorrection.
Okay. So you would probably use DDAVP in the depletion and the diuretics tab while restoring their fluid balance.
So I think oftentimes the scenario that you see, right, is someone comes in volume depleted, they've already received some fluids by the time their labs come back, and we see, oh, they're hyponatremic at this point. So at that point, they've gotten some volume, and I think the volume is obviously good. They needed the fluids, but now they're placed at risk for overcorrection because, their previously adaptive release of ADH is now sort of starting to turn off as their hypovolemia it resolves. And so this is a situation where, yeah, I think DDAVP is often really useful. You can then do DDAVP to stop the correction. It's not going to prevent the beneficial effects of the volume resuscitation that they got. It may make their hyponatremia worse, particularly if you continue to give isotonic volume. And so oftentimes at that point, I'll switch to like hypertonic. So 3% hypertonic saline as the volume moving forward from there.
Okay.
Does that make sense?
Yeah, that makes sense.
A decent chunk of volume often already, then you put the brake on, and then you continue with hypertonic as indicated to sort of achieve your correction goals, which are again about 6 milliequivalents.
And just sort of thinking about a question I always have in my mind is like, seems like most patients who are volume down end up being hypernatremic, right? Like they're retaining a bunch of sodium, they don't have much fluid. So why are some people who are volume down hyponatremic and some people hypernatremic?
Yeah, I mean, it's a great question, and to be honest, the answer is very clear with diuretics. Outside of diuretics, I don't know that I have a great answer for that. I agree. I think we often do see the like hypertonic ones. I think when I do sort of see the volume down ones, it's often a kind of combination of solute-solvent imbalance and being volume down. So someone who is like really sick and has like really bad GI distress. Sure. And so they're not getting solute in, but they're also not getting solvent in. So they have the solute-solvent imbalance, and they're sort of, becoming volume depleted because of their solvent in either.
Gotcha.
So that's sort of the typical one that I think of in that kind of volume depleted. Because again, if someone is,
it's just not typical, really.
Yeah, I mean, if someone had, like our classic sort of like volume depleted states, most of them aren't going to lead to hyponatremia, but it's kind of when you have the combination of solute-solvent imbalance plus the volume depletion that I classically think of that.
So then for the first two, depletion diuretics, we're talking about fluids, maybe slowing it down with DDAVP, maybe speeding up with 3% hypertonic, playing that game, I think. But when it comes to this polydipsia, tea and toast, solute-solvent thing, they're at a normal volume status. So in those people, you may just be giving them electrolytes, salt tabs, or as you said, just like a salty meal with some protein in it.
Yeah, and honestly, for these folks, as long as they're not getting a ton of solute, they're at significantly lower risk for sort of correction than the sort of higher Ds, the volume depleted people. Because again, they're already kind of maximally getting rid of all of the dilute urine that they can. So again, for them, increasing solute in their diet tends to sort of help gradually bring things back up to normal.
So, I mean, is there a certain amount of salt that you might consider giving off the bat in the ED, or is it like
I usually,
salt or like?
I usually don't. I would say for these folks, most of the time I wouldn't do anything acutely in the ED. If they're hyponatremic enough to be admitted, it's then sort of a gradual process of, working with their diet on the inpatient floor. Again, the things that are great are like even frankly more than salt, protein in the diet. You don't want to put these people, if this is polydipsia, on a like acute fluid restriction. Let them drink, but just restrict the amount of fluid that they're drinking a little bit more than what they've been doing. If this is sort of like a tea and toast, encourage a little bit better protein intake in their meals. So they gradually are kind of correcting this imbalance without dramatically shifting the balance.
Right. Okay. And then going over to the right side, cirrhosis, heart failure, these high fluid states, they're edematous. These are probably going to be the patients you're giving a diuretic to.
Yeah, exactly. And diuretics tend to be the sort of mainstay of treatment for sort of hyponatremia in this context. Again, you really don't want to give salt here. And even, it's even tricky with sort of figuring out what to do with hypertonic saline in this context, because again, if you really need to, and it's unusual, but if they have like symptomatic hyponatremia, you might give a little bit of hypertonic to just bring them up acutely. But most of the time, hypertonic isn't necessarily going to be the mainstay for addressing their hyponatremia. It's addressing the underlying cause, which is the volume overload leading to poor kidney perfusion.
Right. Okay. And then going down to the bottom one, your SIADH, obviously you're going to try to figure out the underlying cause of the SIADH, but beyond that, are you going to really do anything acutely?
Yes.
On that first day?
Yeah. So, oftentimes, I mean, again, if it's sort of a relatively significant hyponatremia in the 1 teens or so, I will do hypertonic. If I'm completely convinced that this is SIADH, I don't think that, the underlying cause of the SIADH will be reversed. Then you can just do hypertonic without DDAVP, because again, the person's producing their own endogenous ADH, and they don't really need the exogenous, DDAVP. If I think it's possible their SIADH might reverse, then sometimes I'll give DDAVP as well. So it's still that same kind of process.
Like if it's like a medicine they took that's going to wear off, or a head injury that's going to resolve, or
or I, for some reason, I think it's acute pain that then is going to go away.
Okay.
Again, most of the time I am less likely to reach for DDAVP in this context, because most of the time with SIADH, I don't think it'll be, it'll stop immediately.
Yeah.
And so much of that it'll just be hypertonic, at least acutely. And then chronically with these folks, it's about fluid restriction, and even acutely, of course, with these folks, it's fluid restriction. You want to make sure they're not drinking more than 1 to 1.2 liters of fluid a day. I will often use Lasix as well in these folks, or a loop diuretic as well in these folks. It's anatomy matters, which is why loop diuretics don't cause hyponatremia and thiazide diuretics do. Thiazide diuretics are closer to the cortex, whereas loop diuretics are closer to the medulla. And so the loop diuretic, basically because of this washout effect, really will never cause hyponatremia, or the thiazide diuretic, because it has no impact on the medullary concentrating gradient, does.
Gotcha. Okay. And then mixed edema, coma, adrenal failure, we'll leave those aside, but clearly that's going to be fix the underlying cause. Now, when we're talking about these corrections, what's your general principle for how much we should be correcting and how much time, or upper limits of correcting?
Yep. So the standard of care is 6 milliequivalents per liter per day. And I think that's a good goal for pretty much everybody. You know, if you're doing 6
Isn't
to
that
8,
much, you know, that's pretty small. Like I've seen much bigger swings in sodium in the ED just in a matter of a few hours.
it really is not that much. It's, you know, part of the reason why folks with really severe hyponatremia often are stuck in the ICU for days, just because, you know, you're kind of gradually bringing things up. Again, if I see, you know, 8 milliequivalents per liter per day, I'm not wringing my hands about that, but anything more than that, and you really start to get into significant risk for osmotic demyelination syndrome. Yes, for pretty much all these folks, a fluid restriction of between 1 and 1.2 liters a day is going to be indicated. There are some exceptions there, but you know, hyponatremia functionally is an issue of too much water, and so restricting the amount of water that folks take in will help correct most of these situations. The overall goal is going to be less than 6 to 8 milliequivalents per liter per 24 hours. Again, there are certain exceptions to that rule. You need to treat, you know, acute symptomatic hyponatremia and correct it as much as needed to, you know, address those symptoms. But that's a general principle that you should pretty much always follow.
Love it.
Yeah, you know, it's one of those satisfying things too, where you can pretty much always treat hyponatremia and pretty much always get someone better eventually.
Yeah. Love it. Thanks, man. I appreciate this. This was great.
Awesome. Yeah, no, I mean, I appreciate you you bringing me on, and yeah, happy to chat about other topics in the future if anything else comes up.
I would love that. Actually, could you quickly go back to a slide before? I was just trying to figure out yeah, to go forward one to the urine sodium. Like, this is just for my understanding, like when we calculate a FENA, like that isn't just the urine sodium, right? That's using the urine sodium and putting it into an equation, but we're talking about just the straight urine sodium here.
Yeah, and you know, this is sort of the like subtle distinction between a FENA and a urine sodium. Basically, urine sodium less than 20 is pretty much always going to be like a FENA less than 1. Okay. It is, you know, FENA is probably the more precise measure, because you are saying that the way I think about FENA is creatinine is a much more reliable marker of what came through the glomerulus than concentration is. So the ratio of something to creatinine is a much better marker than the concentration of something in
and
the
the
urine.
FENA incorporates the creatinine into the equation.
The FENA is saying basically for every, you know, molecule of creatinine that came through, how much that came through and then was peed out, how much sodium came through and then was peed out.
Seems like a better measure than just the urine sodium.
And it is. There are just situations where the FENA isn't necessarily useful. For instance, AKI, it's not useful often. Or I should say, when you have fluctuating creatinines, it's not always necessarily the most useful, but it is it's a better marker just because it really doesn't have any post-filtration modification, whereas volume obviously does. It has a ton of post-filtration modification. And so if you're looking at, you know, how much sodium is there for every molecule of creatinine that came out, it's probably a better marker than how much sodium is there for every liter of urine that came out.
So you could do a FENA here, or you could just do the urine sodium as a shorthand.
Right, you could think about this as like a, you know, FENA of less than 1 or FENA of greater than 2. The urine sodium is really just a proxy for, is the kidney trying to hold on to as much sodium as possible, or does the kidney not seem to really care about whether it's holding on to sodium or not?
Gotcha. All right, awesome. Yeah, that was great. That was so awesome. Thank you so much.
Awesome.